Everyone knows Richard Cash because he was the person with David Nayland who actually discovered oral rehydration therapy in Bangladesh. Oral rehydration therapy is potentially the most important medical discovery of the 20th century. And we're very privileged and honored to have him as our commencement speaker.
Thank you very much, and thanks to the faculty and the families and friends, and most of course to the students. In preparing my remarks for today, I asked for the titles of the capstone projects, your final projects, and I have to tell you I was extremely impressed by how many of you had gone directly to the populations to address the public health problems. You were introducing scientific findings into field situations, and projects, I can't list them all. They range from hand washing in Mexico, community acceptability of malaria programs in Niger, oral health in Mumbai slums, kangaroo care in Uganda. You heard about the two who just won, and cultural beliefs in Chinese with diabetes here in San Francisco, to name just a few. So I thought I would title my remarks, Taking Science to the People, because I want to highlight the path that many of you are on, that it takes both good science and working directly with people to develop and deliver successful public health programs. I think to illustrate this, I'm going to tell my own story, part of which Jaime is already related to you, about the development of ORS, oral rehydration solution, and its dissemination in Bangladesh and throughout the world. The story actually began in 1967 when I arrived in Dhaka, what was then East Pakistan, and now Bangladesh, of course, to work at the Pakistan Sito Cholera Research Laboratory. I was fresh from medical school and an internship in New York, where I don't think I ever had a lecture on cholera or diarrhea, even though it was killing millions in the world. I had been assigned by the U.S. Public Health Service to the NIH and then to Dhaka as fulfillment of my military obligation, as all U.S. doctors at that time had to serve during the Vietnam War. Cholera and all forms of infectious diarrhea had long been endemic in Bangladesh, with its many rivers, high population density, low levels of sanitation. And cholera is the most severe of all the diarrheal diseases. It can kill in 6 hours through the rapid loss of fluids and electrolytes from the gut. It's like making a prune from a plum or a raisin from a grape, except it happens in 6 hours. The heart rate goes up, blood pressure comes down, the blood thickens, and the patients begin to lose consciousness. And there's no pain, and the patient quietly slips away. Standard treatment is to rapidly replace the lost fluids and electrolytes with intravenous fluids. But first you need to recognize the problem and have the IV fluids and the means to give it. In those days, in that country, in the rural areas, there was only about one doctor for every 50,000 people, and essentially no nurses. Most people traveled by wind or paddled country boats or by walking. It might take hours to reach a clinic if there was one, but it might not be staffed by health workers, or they might not have enough IV fluid or needles or tubing to deliver it. People waited at home, of course, hoping that the problem would go away, but in doing so, they lessened their chance of survival. You can't have slow motion when you got loose motion. That's, I guess, the moral of that. We decided that what was needed was an oral solution to rehydrate patients and replace continuing fluid losses. Why oral? Well, oral solutions don't have to be sterile. They're much cheaper. They require no special equipment, and they can be given at home because you might not need special medical personnel. Studies conducted in the United States in the 1950s demonstrated that adding a simple sugar, the simplest of sugar, glucose, to a solution of water and electrolytes could move these electrolytes across a living semi-permeable membrane, which is essentially the intestine. Initially, these scientists, with no international experience, of course, didn't make the link between their findings and the possible use in a rehydration solution. Public health doctors and public health personnel working in situ in India, Bangladesh, the Philippines, and so on, that is, lower income countries with a diarrhea problem, did see the link. Science was taken to the problem. Oral rehydration solutions were developed in the 50s and the 60s, and physiologic studies demonstrated that they were well absorbed by the human intestine. The solution contained necessary electrolytes in the liquid stool, which are sodium, chloride, potassium, and bicarbonate. All of these found in the households in the form of table salt, bicarbonate of soda, and green coconut water. To this was added glucose, a simple sugar, and this was the key to absorption. In the first trials in the Philippines, the ORS contained too much glucose and sodium and failed, and people were quite distraught at this. Many also thought it was just too heroic to use these solutions to treat severe diarrhea. It was too simple. We like things a bit more complex. Proof was needed that ORS was clinically effective. So we charged ahead, being young 26-year-olds, 27-year-olds, not knowing that failure was really a possibility. Proof was needed that ORS was effective, as I noted. And our first efforts actually were unsuccessful, as we had no method of treatment. But we developed a method of treatment and were able to demonstrate that in hospital studies, using ORS could save up to 80% of the IV fluid. So now 10 liters could treat 5 people rather than 1, which had done before. We later showed that the ORS could be given in rural clinics and at home, and in all types of diarrhea for all ages. And if given early enough, could even obviate the need for IV therapy. But most importantly, it worked in infants and children, where non-cholera diarrhea, that is the day-to-day events that were occurring, accounted for up to 30% of deaths in this age group. It turned out that it was a universal solution that fulfilled all the criteria of the perfect primary care intervention for a common problem. It was low cost, effective, and easy to use by non-medical workers. Now, this was championed by many, including UNICEF, USAID, and especially the World Health Organization, the organization that set the standards. The WHO approach was to produce a packet of electrolytes, a packet of electrolytes and sugar to be mixed in 1 liter of clean water. The system of care was labeled ORT, which many of you may know, or oral rehydration therapy, to emphasize that the ORS should also be tied to a holistic approach that involved continued breastfeeding and giving other foods to children to hasten recovery and avoid malnutrition. Unfortunately, Western pediatricians, the ones who were writing the textbooks, had recommended that mothers withhold food and not give milk. But where there's undernutrition, withholding breast milk and food can be fatal. In the beginning, after we had demonstrated that it worked, we approached pharmaceutical companies, soft drink manufacturers, anybody who had a distribution system, because we figured that if we could get these packets out to pharmacies and to shops, we could really spread this technology. But no one showed any interest. In retrospect, this was a blessing in disguise. Had we gone the route of distributing 1 liter packets with written instructions to populations that didn't have a liter container and where most people couldn't read, it would have failed. The focus would have been on technology, not how to use that technology. Early on, the value of ORS was clearly demonstrated when its use significantly reduced cholera mortality from about 30% to less than 5% in the outbreaks that occurred in 1971 when 10 million refugees fled Bangladesh during their war of liberation. Despite this, in the early years, the global push to increase the use of ORS did not fare well. Diarrhea continued to kill worldwide. Treatment programs generally relied on the use of these packets. The low use rate was especially disappointing in Bangladesh, where ORS had been developed. But it was a Bangladeshi NGO that cut the Gordian knot of delivering an effective therapy in the home. The organization is BRAC, which is now the world's largest NGO and has recently been listed as the #1 NGO in the world. They literally put treatment into the hands of villagers, reasoning that making ORS was like cooking. The founder and director of BRAC, Sir Fazli Abid, wanted to literally put treatment in the hands of mothers. So he used the most valuable measure, the hand. Experimenting in his own kitchen, he developed a method of home preparation using a 3-finger pinch of salt and a scoop of sugar in 500 cc's, which was a somewhat common container in communities where they produced a lot of milk because this was the standard measure. Following 3 years of field testing with village workers, Brack embarked on a program to teach each and every mother in the country to prepare and use the homemade solution. Between 1980 and 1990, 12 million Bangladeshi mothers were taught to prepare and use the ORS solution, and over 90% could prepare it properly. Today, Bangladesh has the world's highest use rate of ORS, homemade or from a packet designed for 500 cc's. Now, how were these results achieved? I believe it was because they took science to the people. A cadre of women, workers, went house to house, delivering the message and demonstrating to each mother how to prepare the ORS themselves. They were originally given 17 points to remember, which progressively were simplified to 7 points. The key was the pinch of salt, the scoop of sugar, and 500 cc's. As there was no standard container in Bangladesh, the field workers brought their own measuring cup and poured the correct amount of water into a container provided by each mother. A line was then scratched on the inside, and the mother now had a no-cost 500 cc container. WHO was initially quite opposed to this program because the standardized packets were not being distributed. They spoke against it, lobbied the government to ban the program. How wrong they were. Now, I also should note that this was not a static program. There were at least 15 revisions as they continued to simplify the message and its implementation. When use rates stagnated, field supervisors discovered that many workers really didn't believe that this stuff worked. So they were shown actual patients as they recovered, proof by experience, and growing enthusiasm for the program. A unique method of evaluating both the program and field workers was developed. Though field workers couldn't force mothers to use the solution, they could ensure that each mother knew about it and how to use it. The workers, therefore, were paid on the basis of how much the mother learned and remembered, as determined by independent evaluation 3 weeks later. Salaries increased then if mothers knew more, so field workers continued to come up with new ideas to improve their performance. For example, they began to understand that men also were decision makers when it came to the treatment of children, and so they brought the message to them in the marketplace. They tasted the ORS to ensure the mothers that this was not a contraceptive product, as the only female workers who had previously come to the villages were family planning workers, and villagers were suspicious. They developed and refined the method of measuring the correct amount of water, and they worked on their teaching techniques, emphasizing the skills of mothers. Globally, deaths from diarrhea are down from 4.5 million in the mid-60s to less than 650,000 today, still too many, but a reduction of over 95% using today's population. Better quality drinking water, vaccines, especially measles, maternal literacy, smaller families, along with ORS have all contributed to these dramatic reductions. We're enamored with ideas that seem to spread with little effort. We've all got our iPhones, Facebook, Twitter, and so many other, but the spread of information itself doesn't lead to behavior change. It's people talking with people. Experience remains the best teacher, but we need to marry the science with this experience. You'll be making the science people connection throughout your life's work. You will need to harness the power of science by taking it to the people, by listening, adapting, and where possible, simplifying. I've no doubt that individually and collectively, you will make significant contributions to global health. And there is much you can teach others. That's for certain. You're entering a very exciting field at a very exciting time. Just be sure to keep listening and adapting. I wish you the very best of luck in your work as members of the global health community. Congratulations to you all.